Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is titled Bone Health, Osteoporosis, and Vertebral Fractures. The presenting provider is Neurosurgeon Todd Nida. Dr. Nida sees patients in Pontiac and Clarkston. Welcome, Dr. Nida.
Hi, good afternoon. And good afternoon to everyone out there this nice snowy day here in Metro Detroit. Hopefully everyone is safe, warm, and cozy. So my name is Todd Nida. I'm a board certified neurosurgeon. I'm originally from Minnesota. I went to, for those of you that are old enough to have watched the Golden Girls, I did my undergraduate down on the hill at St. Olaf College, and then did my medical school at the University of Minnesota, Minneapolis, and also did my residency training in Minneapolis as well. And then I came out to the Michigan area, primarily Oakland and Macomb County, where I've practiced now for about 30 years. I do general neurosurgery, which includes a spectrum of problems. I don't do every type of problem in neurosurgery, but one of the things that we do quite a bit of is management of vertebral fractures. So this talk is going to focus a little bit on some basics about general bone health. I'm going to focus mostly on osteoporosis, and then kind of evolve a little bit into some of the treatments that we have for osteoporosis, especially the vertebral compression, fractures. That's kind of the direction we're going to go here. So, and again, if you have any questions along the way, make sure to submit them via the QA, and we'll try to answer as many questions as we can. So I want to start this talk out, with the holiday season coming up here. I know a lot of people are going to be probably going out to holiday parties and stuff, and I just want to know if everyone really knows, why you're not going to see any skeletons at these parties. It's probably because they don't have anybody to go with. Anyway, so we're going to talk a little bit about, what is bone. So bone's a living tissue. It's a relatively rigid connective tissue, and it makes up our body's skeleton. Cartilage, for example, is another living tissue, and it's a connective tissue, but it's obviously cartilage is not rigid, and cartilage doesn't have, and at least an adult doesn't have vascular supply, nerve supply, lymphatic supply. So cartilage is a good supporting feature, but bone is really what gives us our structure, what people think about when they talk about the skeleton. And we've got two different types of bone. Usually, most people are familiar with this. There's the very hard outer part of the bone, which is usually referred to as a cortical bone. And then on the inside, you've got the cancellous bone, or what we call it trabecular bone. Next. Next. So what kind of materials do we find in bone? The primary player in bone construction or bone health is going to be your collagen, which is a very ubiquitous protein that's within our body, and it's a primary building block for bones. And then, of course, it's going to be supplemented by some of the other inorganic materials, including the calcium phosphate. You're going to find blood vessels within bone as well. And importantly, there's a lot of living cells within the bone, and we're going to talk a little about some of the more important cells that play a role when it comes to bone health, and especially osteoporosis. And those would be the osteoblasts, the osteoclasts, and then the osteocytes. Next. So a lot of us know the general functions for bone. Some of the functions are pretty obvious to people. So it provides, support and structure. So it allows us to stand tall and to be rigid and be able to function. A little bit different than, for example, an octopus, which is an invertebrate, doesn't have bones. So being vertebrates, we have bones. They do provide support and structure. They're responsible for protection. The skull is the most obvious example there. The skull protects our brain. We've got our sternum and our rib cage. It protects vital organs within the chest, the lungs, and heart. Bones are also important for movement, although we all know that the bones themselves aren't doing the moving. They're kind of more the levers that are involved and supplemented by the joints and the cartilage ligaments. But they're obviously very important in being able to create at least the type of mechanism or movement that we have. Um, Bones are very well known for their blood cell production. Um, they obviously produce a lot of the precursors, stem cells, and produce our blood cells, etc. And the bone is very important for mineral storage, especially calcium, because our body uses a lot of calcium in day-to-day cellular mechanisms and stuff. So it has to have that place to put it and stuff. It's going to interact with the parathyroid and other hormones to store and save and release calcium. So calcium is available for not only for bones but for other body mechanisms. And then there's some important roles of bone with regards to hormonal function, the interactions between estrogen, calcitonin, and other hormones within the body. Now, one of the most important things to recognize, and I didn't even recognize this for a long time. I'm not even sure in medical school if I even remember this point, but bone is just one big continuous remodeling cycle. Is a bone is not static. It's not like you grow up and all of a sudden you're adult and you've got your bones and they're just bones and they age and get old. Although they age and get old, they don't. There's a constant remodeling cycle here, and it's a very very regulated process. There's a continuous coordinated management where you're getting bone loss and then bone rebuilding, and it maintains a nice homeostatic good health function. So this is very continuous. It's a physiologic process that occurs throughout our whole entire lifelong process there. Kind of one fun fact is that the entire human skeleton is basically replaced about every 10 years. So that means for a lot of people, your skeleton is going to be completely new and replaced, several times, 7, 8, times during your whole entire lifetime. So, and again, we're going to talk a little bit about some of the players that are involved in this recycling process. It's kind of a balance between the function of the osteoclast, the osteoblasts, and then the osteocytes. Next. Okay. So the main players are, you can see on the slide here. Think of the osteoclast as the bones demolition crew. So they dissolve and break down damaged bone tissue, just as a demolition crew would take down an older building or structure. And then you've got the osteoblasts on the other side, and they're kind of considered the building crew. They're the ones that are now laying down new bone and doing the remodeling. And then you've got the osteocytes that you could picture as being a job site, supervisor. They kind of regulate the interaction between the demolition crew and the building crew. They try to keep the peace and try to keep everything working well and keep everything real balanced. So what happens when this delicate balance in bone remodeling is out of whack, no longer working? There's a lot of different disease processes that can occur. I'm gonna focus mostly on the process of osteoporosis, but there's some other diseases that occur. Some of them are genetic, some are acquired. Paget's disease is one in which the building crew or the osteoblast is a little bit more active than the osteoclasts, and you end up with kind of bigger bone, but it doesn't have the right structure, and it ends up being more susceptible, being weak and not as healthy. And then you got the osteopetrosis, where the osteoblasts are going crazy and the osteoclasts aren't really working, so you're just getting a lot of hard bone built up. And then there's some other ones, the nutritional, rickets, and people with renal disease, kidney disease will have issues, and there's some other congenital abnormalities. But it's really kind of the osteoporosis that we're going to touch basis on here, since it seems to be a lot more prevalent and a lot more, pertinent to most people. So when we talk about osteoporosis, what we're talking about a condition where there's an excess loss of bone. And as you can see from the picture on the right, there's not only a deterioration of the bone mass, but there's a kind of a general change in architecture. You can see the healthy bone on the left there, where it's fairly dense architecture, is very consistent. And then you look at a diagram with the osteoporosis, and it's a lot more irregular. There's big cavities where there's a lot of mineralization and stuff. And this obviously contributes to problems. And most importantly, it compromises the strength of bone, and then unfortunately, it leads to a much higher risk for developing fractures of bones as well. Um, Osteoporosis generally results from too much activity of the osteoclasts and not enough activity of the osteoblasts. And so you end up with a kind of a general reabsorption. The reabsorption or subtraction of bone actually starts to exceed and overtake the deposition or placement of bone. So you basically have, in my example, you basically have a demolition crew that's going crazy and outworking the building crew. It's kind of what ends up happening with osteoporosis there. So next. There's two types of osteoporosis. We're going to focus mostly on the primary type, but the primary type is just more common in females. Obviously, post-menopausal, more common with age, kind of natural physiology and aging. Secondary occurs to some other factor that someone might have in their life, and there's a lot of different reasons for this. On the bottom, I've kind of highlighted the corticosteroids. So this one probably the most common secondary factor we see. So people, for whatever reason, it could be they have asthma, bronchitis, they're on chronic inhalers with corticosteroids, and some people have allergies, immune problems, are on corticosteroids, rheumatoid arthritis, other immunologic issues. So secondary osteoporosis can occur mostly from corticosteroids. You tend to see a fair amount also in people with the renal failure, and dialysis can occur as well, but other nutritional issues, etc. and stuff. So the demographics of osteoporosis are pretty overwhelming, because it's obviously it's a worldwide problem. It's not just a Michigan problem, Metro Detroit problem. It's a worldwide problem, and they say there's about 200 million people affected worldwide by osteoporosis, and most people are aware of the fact that women are at significantly higher risk than men. About 1/3 of women over the age of 50 are affected, as opposed to only about 1/5 of men. We find that the incidence of osteoporosis obviously increases with age, and by the time you get to be 65 years or old, there's a prevalence of about 27.1%. So almost a third, not quite a third of people. Turns out that the non-Hispanic whites and Asian women are at higher risks as opposed to African American. There's a lot of other factors involved in development of osteoporosis. Some of it's genetics, which can affect your body frame. We know that people that are very thin and very tall tend to be a little more susceptible. Certainly, people that have parents that had issues with osteoporosis, especially at a younger age, are more susceptible. Lifestyle plays a pretty big key there too. Smoking or tobacco plays a role. And also alcohol use is a significant issue towards osteoporosis as well. The one thing I learned a long time ago, and I always kind of tell my younger patients, because it doesn't help as much to tell patients that are a little bit older, but humans actually achieve their maximal bone density or the mass in the third decade of life, which means that at about age 30, your bone density is pretty much as good as it's going to get for the most part. And not everyone's the same. Some people are much different than others, and obviously the first 30 years of your life kind of dictate where you're at age 30. But after age 30, there's a slow loss of mineralization from then on. So that where you're at age 30 a lot of times dictates where you end up age 65 and stuff. So I always tell my younger patients when I see them a little bit about that, because that's the best time to probably intervene with that. But if you have younger family members or grandchildren or stuff, I always remind them that it's important to take care of your bones up front, because it's going to have to last a long time. So how do we measure osteoporosis? We kind of know what osteoporosis is, but how do we measure it? And the gold standard is really what we call DEXA scanning, and hopefully many people out there, especially over the age of 50 or high risk, have had a DEXA scan. But that's a dual energy X-ray absorption study that is very effective. Many times as a surgeon, I look at a lot of X-rays. Radiologists look at X-rays, and you can get a little bit of an idea from the X-ray as to whether or not someone's bone health is good. You can make a generalization. I can look at an X-ray and say, gosh, you know what, this looks to be a little bit less than normal. It's at least osteopenic, or oh, this is really bad. That's osteoporosis. But that's just kind of subjective. But the objective measurements really come from the DEXA scan, which is a painless test where they scan your bones and take measurements and stuff. The results of the DEXA scan are reported in relation to a standard deviation of the general population. So we don't have there's not just an inherent set number where we need to be. So what they've done is taken a pool of the general population and done measurements to see, what's kind of generally considered to be normal. And that's kind of set at the standard. So you'll most commonly see bone density testing reported as a T-score. Now, a T-score is a score where they're taking the measurements from a young, healthy population as kind of the baseline, and then they're comparing you to that young, healthy population. That's the way you typically see it, but they will also oftentimes present it as a Z-score. And a Z-score is trying to take an same age person. They're taking people between the ages of over the age of 65, and they're comparing you to people your same age, and that gives you kind of the Z-score. So a lot of times you see them reported, both ways, but that's what they're in reference to. So this goes to show that a normal T-score would be considered basically less than one standard deviation away from a normal. And on the other spectrum, you've got the osteoporosis that is more than 2.5 standard deviations away from the reporting normal. And then people kind of between normal and osteoporosis kind of fall within that kind of that osteopenia range. So that's how we tend to use those terms. So how do you manage osteoporosis? So a lot of osteoporosis management can actually start, at home. We talked a little bit about lifestyle management. So both smoking and alcohol contribute to changes within the body that result in tissue damage, free radicals, and other factors that tend to affect bone health. So obviously not being a smoker and curtailing your alcohol use will probably help you in the management of osteoporosis in the long run. Nutrition is fairly important as well. Most normal people with a good healthy diet, probably don't necessarily need to be taking calcium and vitamin D. The best source of calcium and vitamin D is obviously going to be in the natural diet. You're going to get the most common sources for you are going to be in your fortified dairy products. So a lot of our dairy products are fortified with calcium, at least, and you'll see that in your milks and your yogurts and cottage cheeses and stuff. But you can get good both vitamin D and calcium in some fish with bones. For example, canned salmon or salmon. Believe it or not, if you like sardines, sardines have a lot of calcium and vitamin D in there too. And then there's some vegetables that will have a lot of fair amount of calcium. They don't have vitamin D, but you can have the green colored greens. You probably have kale, broccoli, and one of my wife's favorites, which is the bok choy. Those are pretty good source of calcium there too. So if you fall into a category where either you have known osteoporosis or you have a significant dietary deficiency and stuff, then you may want to supplement with a calcium and vitamin D, tablet. For the general population that's generally healthy and eats well, it's kind of controversial as to whether or not younger folks should be taking this stuff routinely or not. Go back one. So exercise is also a key. So, but it depends on what kind of exercise you do. Um, Bone is very sensitive to stress fracture, to stress. So there's a reason why our femur bone is, the strongest bone in our body. That's the leg bone, but our femur, our leg is a big bone, very strong bone because, we're upright. We put a lot of weight on it. And then you've got, smaller bones in the wrist and the hand and finger, which are much smaller because the bones are very sensitive to the stress and stuff. So when you get exercise for osteoporosis management, it needs to involve a little bit of weight bearing or resistance because the bones have to feel a little bit of tension. So even though I recommend aquatic exercise, a pool to a lot of my patients with back issues because it's a real friendly environment for them, I always tell them, I say, you know what, the pool itself is probably not going to be a great environment for your osteoporosis. It'd be like the astronauts in outer space. When they come off the spaceship after a year, their bones are pretty well depleted. And it's the same thing there too. So you want to get kind of weight resistance type exercise, obviously muscle building and strength to help support the joints is good. And then work on balance and some flexibility because good balance is going to lead to the next prevention, which is actually reduce your risk of falling. So obviously, as people get a little bit older, there's a number of reasons why balance becomes a little bit more of an issue. So working on balance skills at the gym, if it's there's a lot of adult classes where you're working a lot of balance, but balance can help quite a bit as well. And then you start getting into, once you've exhausted those, and you start to get into some of the medication options that you can discuss with your physician. So when it comes to the pharmacologic treatment of osteoporosis, or the medical management of osteoporosis, there are kind of two categories of medications that are currently available. They fall into two categories. One is the anti-resorptive therapy, and the other is what's called anabolic therapy. So anti-resorptive therapy is intuitive. It's kind of like what it sounds like. It's basically slows down the reabsorption or breakdown of bone, or it's kind of sends a demolition team on brakes and kind of slows them down a little bit. Um, the more common one, I'm not going to go into great detail of these medications, but in the orange category up to the Fosamax would be kind of one of the more common examples of an anti-resorptive therapy. But there's some newer medications there. The calcitonin, the blue box there, the calcitonin, that's actually a naturally existing hormone that's in part regulated by parathyroid. But the giving someone some calcitonin can actually help with the building of bones by improving the function of the osteoblast. So, and for some people, especially obviously women postmenopausal, that might be a little bit more either have allergies or refractive to some of the medications. There's some role sometimes for estrogen treatments as well. The other side of the treatment is the anabolic therapy. So there are some newer medications that actually help with actual building of bones. So you got one category that tries to slow the tear down, and the other category that's really trying to start to motivate the building team and to build more healthy bone. And just a couple of examples here. The human parathyroid hormone is actually an engineered variation of the same hormone that's normally released by the parathyroid gland, which is next to the thyroid. So trying to supplement that. So those are some of the medical things. And like I say, you're talking, getting your DEXA scan, talking to your primary care physician, looking at the lifestyle factors and stuff, and then your primary physician can work with you with regards to as to whether or not one of these medications might be appropriate for your situation. So one of the problems with osteoporosis is it's it's kind of a silent disease until it isn't. Um, a lot of people, recognize as they get a little bit older, they maybe a little bit shorter, they're a little more hunched over, but other than that, until you have a problem, it doesn't seem to bother a lot of people. But the fragility fractures are the most common, and what we mean by fragility fracture is a broken bone that results from a relatively low energy mechanism. So from some sort of activity that you might not normally expect. I've actually seen people that have some people like this time of year. Lady was going to open her sliding glass door, and it was a little bit of an ice jam, and she was just kind of doing that. And that was actually enough to cause a problem. I had a lady one time was taking a 15-pound turkey out of the oven. But you tend to see it with things like that. It could be other lifting activities, and sometimes it's kind of spontaneous. But we see the fragility fractures most commonly in the spine. They probably outnumber the other fractures at least 2 to 1, but you can see fractures in the hip as well as the wrist, which could be more common with falling, obviously, as well as the shoulder. And pelvis and ribs are also pretty common there too. So I'm going to focus in a little bit on what we call vertebral body fractures or compression fractures. There's a lot of different types of fractures of the spine that we see. Many of them are traumatic. You see them due to accidents, younger people and stuff. But and even younger people sometimes can have the compression fracture type. But the compression fractures are the ones that we tend to see in people as they get a little bit older, especially with osteoporosis. And they occur, I think this might even be underestimated, but they occur at least 1.5 million times every year in this country. Seems like we see a whole lot more, but they're twice as common as other types of fractures in the body due to osteoporosis. It's estimated that about 25% of postmenopausal women over the age of 50 probably have already had a fracture. And that's in part due to the fact that a lot of these fractures are asymptomatic. So there are people that come in sometimes and they get a chest x-ray because they've got a cough, and all of a sudden on the report there's discussion of a compression fracture at T8, and someone didn't even know that they had it. So that happens quite a bit as well. They can lead to pretty serious morbidity. One of the issues with successive compression fractures of the spine is that if it's pretty severe, you've probably know someone who's probably lost about four inches. They were 5'7", now they're 5'2", and you look at them and they're hunched over. The spine is very curved. But every time you get a fracture and the vertebral body collapses down and the spine collapses over it, it makes the thoracic space less. It diminishes the thoracic space, so it starts to compromise respiratory function and stamina, and that can be an issue. Not to mention the fact that when you have vertebral fractures, especially if they're painful, then it starts leading to less activity, less independence, and more sedentary activity and other problems that stem from that. The thing to know is that if you do have a vertebral fracture, you're got about 5 times likelihood that you're going to have a second one. So unfortunately, once you've had one, the likelihood of having other fractures is greater. So even the better reason to, if you aren't already evaluated by DEX or aren't treated with your primary care physician, to really look into it if you've had one. And we see it most commonly at the thoracolumbar region. That's between T12 and L2. That's kind of the upper back region, transition between the rib cage and lower back. It's the rib cage is relatively rigid, and you got the lower back. It's an area where there's a lot of stress and stuff with lifting and bending, torque, etc. and stuff. So this is an example on the left. So if you have an X-ray of a vertebral fracture, you can see that this vertebral fracture here is compressed. The vertebral body above at T12 is normal shaped, rectangular. The vertebral body below is a normal shape, and you've got this compression. Now this one looks relatively fresh due to the change in the end plate. But the thing about these vertebral fractures is that oftentimes on X-rays, it can be difficult to know if they're new or not, because a lot of people have had an incident and may have known someone who had had a fracture of the back when they were a kid when they were sledding. It probably was a compression fracture. People sometimes have fallen off of horses. Construction people have had falls. So a lot of people have had compression fractures of the back for other reasons in the past. And when these fractures heal up, they always stay trapezoidal or compressed. They don't heal back to the rectangular shape. So now we got a bunch of people coming into the emergency room because they low blood pressure, they passed out or tripped on the dog or slipped on the ice, and you get an X-ray or CT and you see one of these compression fractures, and it can be a little bit hard to know, in fact, if that's new or not. So we typically would do an MRI for someone that's symptomatic, that has localized pain, has an X-ray or CT that suggests a fracture. We'll do the MR imaging if we think more aggressive treatment might be needed. And the MRI actually shows a good example here. The larger larger arrow here actually shows an acute vertebral fracture. The vertebral body is collapsed about 50% on the front. Um, there's whitish changes within the bone marrow, which are inflammatory or reflective in acute fracture or edema. And that's by comparison to the one above. So the vertebral body above that also has a vertebral compression, but actually we can tell by MRI that that's an older compression. There's no edema, no acute change within that. So if we were going to treat that with a procedure, we would be targeting the symptomatic one. Let me get a good look at the spinal canal here too. Most of these fractures compress down. We don't often see much pushback of the bones back here, so that's typically not a big issue. So how do you know if you have a vertebral compression fracture? And the answer is sometimes you won't, because they're not always symptomatic, but those that are symptomatic will typically report a very sudden onset of back pain. Um, sometimes it's pretty localizing. Sometimes it's, they'll narrow it down to a very small area. Sometimes it's kind of across the lower back, and sometimes might extend down to the buttock or hip. But generally, there's a sudden onset, and it's aggravated by movements. So what we call transitional pain. So when I talk to someone about the pain, I'm always asking, so what happens when you get up? What makes it worse? What makes it better? What happens when you roll over in bed? And they usually will find out, people that have the fractures, they can get comfortable in bed. They got a pillow, they're laying there, their pain, might be a 1 out of 10. It's tolerable, but rolling over in bed makes them miserable. Trying to get out of bed, it's miserable. When I see people in the office, I always just watch them just get out of the chair and stand up, because some of them get out of the chair and stand up and sit down pretty well without a lot of pain. Probably doesn't have an acute compression fracture. Loss of height. Some of the asymptomatic ones, people generally that report, they've lost height over, as a reflection of underlying loss of fractures. And the fractures don't always have to be, as dramatic as the ones I've shown. You don't have to have, 50% loss of height to be a fracture. I mean, if you got 5% compression of multiple vertebral bodies, it all kind of adds up. You can very easily lose a couple inches of height and start to stoop or kyphotic posture. That you see, that's also very indicative there too. People start to also to lose general spinal mobility and stuff. And like I mentioned, it's pretty rare that you can see sometimes these vertebral bodies, as they fracture, some of the bone will go back and may contribute to what we call stenosis or narrowing of the spinal canal. But that doesn't occur all that much. Mostly it's pain for most people. So here's how we treat vertebral compression fractures, and with the one exception of maybe some of the medications that are newer and the surgical treatments, these ones up top are kind of the mainstays, and these are the only treatments we actually had for a long time. But in the last 20 years, we've got better methods to treat these. But most people will start with more common medications. If someone doesn't have an adversity or reason they can't take a NSAID, like ibuprofen, we'll use ibuprofen, Tylenol, might use a muscle relaxant, topical patches like Lidoderm, ice packs, and probably mild analgesics. A lot of times we're dealing with older populations. People don't always tolerate the opioids all that well, so you have to be a little little bit careful. And that's a lot of times that is actually what kind of prevents from getting good pain management, because a lot of people just can't tolerate the stronger medications, and some of these medications just, aren't sufficient and stuff. Uh, Intermittent rest and activity modification. Most people with vertebral compression fractures can tolerate the pain and survive as long as they're sedentary. But most people don't want to just lay there in bed or sit in a chair. But I mean, obviously, they're going to have to make some modifications. We oftentimes will use a back brace to kind of limit motion and provide some comfort. It's a common modality we use. It's kind of controversial. It's a lot of argument as to how effective it is and if it really makes a difference or not. Some people feel more comfortable using the brace. It gives them more confidence. Some people can't wear the brace. They're obese, or they're hunched over, and the brace is right up into their chin. So not everyone's a candidate for brace, but a lot of times we'll try doing that as well. And then it's not so much right off the bat because it hurts a lot, but vertebral fractures, if they're relatively tolerable, they respond to some of these medications. You can actually kind of ride them out if they're on the lower spectrum of pain. And then eventually, as people start to get a little bit better, you can get into some physical therapy, which will help. Obviously, this is a wake-up call for a lot of people. If you've not didn't know you had osteoporosis, hadn't really ever been checked by your doctor, and all of a sudden now you've got a vertebral fracture, it's a good time to get your DEXA scan, talk to your physician, and possibly start some long-term treatment for the osteoporosis. Now, that's not going to help you a whole lot when you're in a whole bunch of pain, because this fracture hurts a lot and you're real limited. And that's where some of the surgical interventions come in. I'm gonna talk just a little bit about some of the interventions and things we can do nowadays to help with these fractures. So there's basically the surgical interventions can really be described as we call them cement augmentation. So, but there's two procedures that really kind of fall within the cement augmentation, and one is the vertebroplasty. The second is the kyphoplasty, and they're both very effective for treating painful fractures. They're a little bit different technique, but they are both fairly equally effective in the pain relief. And the kyphoplasty has a couple of added benefits, and that's a procedure that I've done primarily for the past 20 years. So kyphoplasty is a procedure that evolved around the year 2000. The vertebroplasty was the first procedure. Vertebroplasty just involved putting a needle into the fractured bone and then pushing some cement in there. That procedure came out first, and then kyphoplasty kind of evolved from that, where we said, well, let's not just put a needle into the fractured bone, but let's inflate a balloon that kind of helps lift the fracture height kind of back up. It creates a little bigger cavity for the bone cement, and then you put the bone cement in, and that's what kyphoplasty is. So it was introduced in 2001 for widespread use. It's in the United States, it's performed, I think it's even more than this, but at least 19,000 times per year. And it can be performed either in there's some offices that have procedure rooms and a C-arm that will do it. Surgery centers, or I do most of mine primarily in the hospital. So a lot of times patients will come in to the hospital after a severe onset of back pain, or they had a fall with real bad back pain, and we just can't really get them comfortable. So in order to be able to get people up and moving and out of the hospital, we have to kind of intervene. So a lot of the kyphoplasties will get done in the hospital setting as well. They can be done effectively. They're extremely safe. And the best thing about them is the pain relief is really, really rapid. It results in most people, it results in almost 99% relief of pain. So it's very rapid relief of pain. And as a result, then people can function, people can get out of bed, they can move around, start getting back to their regular activities, and it greatly improves the quality of life, as opposed to sitting around in a chair with with pain and taking ice packs on your back and being real limited. one of the advantages of the balloon procedure, the kyphoplasty, is that it also does restore some of the height to the vertebral body. So in a person, and I've had, like I said, as I said earlier, that if you have one vertebral fracture, your likelihood, you're about 5 times more likely to have another one. And so I've got a few, more than a few patients in my practice that I've been treating over the past, several years, and it's just kind of one vertebral fracture, kind of after another every few years. But the good thing is, if you do the kyphoplasty and you can restore some of the height and repair it, you can kind of avoid a lot of the kyphotic, curvature. So, and that's going to be better for the patients as far as their posture, mobility. People don't get the secondary pain from being hunched over. Usually, when people get hunched over, then they start to crouch and throw their hips forward a little bit to try to stand up so they can see where they're going. That creates lower back problems, and also it improves respiratory function because your thoracic cavity, isn't getting so constricted and affected there too. And of course, the pain relief, when you do a kyphoplasty at one level, it generally is sustained. If you do it right, they don't refracture. It doesn't hurt again. You get sustained relief, at least from that level you've treated. So this is kind of an example a bit of how the procedure is done. So on the far left, an example schematic of a vertebral fracture, compression fracture. This one's fairly modest here. What we do the procedure is we put in a needle using, usually it's fluoroscopy or live X-ray, typically two machines we'll call biplane, but we put the needle in through the pedicle into the vertebral body. We create a little bit of a channel within the fractured vertebral body, and then we put down through this cannulated needle, we put in a balloon. The balloon obviously is not inflated until once it's in the vertebral body, but we put the balloon in the vertebral body, and then we kind of gradually inflate it. And this schematic, it kind of exaggerates, shows a little bit what happens. On the left, you can see the compression, and then after the balloon is blown up, you can kind of see height restoration. And then the balloon is taken down and taken out, and then we put in bone cement. It's basically it's a plastic cement. We call it bone cement, but we push in some bone cement into the vertebral body to fill the cavity and hopefully to kind of interdigitate amongst the trabeculations, while being careful that it stays within the vertebral body and doesn't extend outside the confines of the vertebral body. There too. Next. So I call this the Band-Aid procedure when I'm talking to my patients in the hospital and trying to not necessarily convince them to have it, but trying to talk about the different options. I always say, you know what, you come out, you come out with two little Band-Aids on your back, and it's a short procedure. Most of the procedure is the setup. It takes a little time to set up and get machines in there, get set up. But once we start the procedure, it's 10, 15 minutes at most. You can do it either with general anesthetic or sedation. I've done it both ways. I kind of like to do it with a general anesthesia because turning older folks having to kind of, patients have to be prone or on their stomach on a special frame for this. So an older patient that's got a lot of pain and stuff, trying to kind of move them over while they're sedated, and they get restless, and it's slower. I can work a lot faster and a lot more effective with general anesthesia. Nowadays, the anesthesia is so safe that they can put people under and wake them up so quick that it works out really good for me. And the good thing is people go home a couple hours later. I get a lot of people that I see in the office. We set them up. They come in the morning. We do the procedure. They're home before noon. And I tell people, hey, just take it easy for the day. You know what? Tomorrow you're good. That cement sets up. It hardens pretty quick within a couple hours. And really by the next day, you're basically as good as you're going to get. The pain will be mostly gone. You'll have a couple of Band-Aids on your back. It might be mildly sore from the puncture site, but you can get back. There's no restrictions. It's not like a knee replacement, where you're going to, sitting around waiting for the swelling to go down for weeks, and then you go into therapy, and then you're working on range of motion, and then you're working on, 3 months, 6 months out. This has been a 1 day recovery. So it's really been a godsend for a lot of patients, and a lot of people that are a little apprehensive up front about the first one. When they come in the second time, they're always like, sign me up. I just want to get this thing fixed. And it's been a really good procedure. So we do have ways to treat vertebral fractures. Generally, they're effective. Um, we can go about as high as about T5. So that's about nipple level. When we start getting a little higher up, you do sometimes see compression fractures T1, T2, T3. It's hard. Technically, it's very hard to do the procedure because the X-ray machine then has to compete with the shoulders and the heart, and you just can't get good imaging across that part of the body. So we typically restrict these to people that have acute compression fractures from generally T5 down to the sacrum. There's a separate procedure. I don't do this procedure, but there are patients that'll have what are called the sacral insufficiency fractures, and there's a similar type of procedure called sacroplasty that involves putting the needles into the sacrum and putting cement in. So there's ways of dealing with most of the spine, at least from T5 downwards. And that's pretty much all I'm going to talk about today. Hopefully, I left a little bit of time for questions. I was in private practice for nearly 30 years here, Oakland County, Macomb County, and last 2 years now, I've been working primarily for Trinity Health, primarily the Oakland Neurosurgery campus here in Pontiac. So I've got my name and number. This should actually be 44555 Woodward. That's misprinted, and phone number there too. Um, but we're always willing to evaluate patients or family. And if you have any other questions, we'll always try to help you out any way we can. So if there's any questions.
Okay, there are actually a number of questions. So let's get started. If you haven't found the Q&A feature yet, it is at the bottom of your Zoom screen. Feel free to drop a question in there at any point. And with that, we'll kick it off. So there are some questions about different exercises. So somebody is saying they have osteopenia. I'm not sure if I'm saying that correctly. And they're wondering if yoga poses are, or if there are any yoga poses they shouldn't be doing. And then another person is asking about Tai Chi for bone strengthening. Do you have recommendations on either one of those?
Um, I do. I'm not a master of yoga, so I don't know like every single pose, but I mean, generally I favor both yoga as well as Tai Chi. It's kind of more the resistance type thing. So whether or not you're using like in yoga, a lot of times you're using a body position, where you're holding your body up or you're doing something, that is creating some resistance and is good for bones. And the same thing with Tai Chi. The thing with when you have osteoporosis, you kind of want to stay away from the impact things because you get to the point where you get we call them fragility fractures, but it takes a lower amount of energy sometimes to precipitate fractures. So, people I get a lot of people, and it's like, oh, I love playing pickleball, and pickleball is definitely a little bit of a higher risk. I think if you play pickleball in moderation and you're not trying to be world champion and you want to go out there and have some fun, at your own risk is probably okay. But even if it's lighter weights, it doesn't have to be heavy weights. It could be 1 or 2 pound weights. Resistance bands are really good. You can get the resistance bands where you can use them in different ways. You can even stand on the first step and just do kind of toe lifts and stuff like that, or even just practice like getting out of a chair without using your hands to stuff. It doesn't have to be really hardcore exercise to get the benefits. So the point is that it's got to be a little bit of weight bearing. So even though I like swimming, and there's probably if you're swimming laps, there's probably some benefit to certain muscles, but swimming is great exercise, but probably not as helpful for bone density. And although jogging and running can be considered good exercise, it's a little bit more of an impact activity. So, if you do insist on jogging, you might do, treadmill or a track where the surfaces are a little bit better there too. But I think both Tai Chi and Pilates Tai Chi, Pilates, and yoga are great exercises for back health.
Okay, great. This person is asking, it looks like they're a 40-year-old breast cancer patient who's taking a GLP drug and wondering if osteoporosis can be reversed, and if so, how can they do that?
Um, it's osteoporosis can be treated and it can be improved a little bit. It's difficult to entirely reverse. So with aggressive treatments that might include some of the medications I alluded to and modification of other risk factors, you can see improvements in T-scores on subsequent DEXA scans, but it's not really reversing it. You're kind of trying to slow it down and try to improve it, a little bit, 10-15%. It's not going to be completely, reversible, unfortunately.
Okay. Okay. We talked about alcohol and smoking, but how about cannabis? Does that affect bone health?
That's a good question. Um, I didn't specifically research that one. I probably should have, guessing that it might come up. Both alcohol and tobacco, a lot of their negative effects have to do with the way that the toxins and those substances are metabolized and the development of what's called free radicals and some subsequent tissue damage there too. So I would I probably would imagine, I haven't researched it, I can't say for sure, but I would guess that there's probably some adverse effects of either vaping or cannabis, but I can't be for certain on that one.
Okay, and how about caffeine and things like Diet Coke?
Uh, um, they do. I mean, excess caffeine does help leach out calcium out of the bones, so that's definitely kind of falls into the dietary risk factor of either not getting enough supplemental calcium within your diet or other things that can kind of leach calcium out, like corticosteroid use, caffeine. It does have some impact. I mean, if it's excessive, I mean, a little bit of cup of coffee, 1 or 2 cups of coffee is supposed to be good for your general health as a whole and stuff. I don't think one Coca-Cola is going to be a problem, but I think excessive um, sodas probably have impact on it.
And is it helpful to add collagen peptides in your morning coffee?
That that is interesting because it's there's no it's it may help with bone health, and because obviously the majority of the organic matrix of the bone is collagen. And we know that collagen is very important in a lot of structures, including skin health, hair, etc. and stuff. So they, for people that have risk factors, for example, with the GLP-1 agonists, one of the biggest issues that people see sometimes with the rapid weight loss is issues with the hair. So there's some recommendations that the peptides, protein peptides in coffee or not and a beverage in the morning could be helpful. I mean, it's not the, the there's not a strong study to suggest it, but it's become fairly popular and stuff. I don't think there's much downside to doing that.
Okay, there's a question about the word morbidity. VCF leads to morbidity. They're wondering, what do you mean by that?
Mm. Well, there's 2 words we typically do, and they sound relatively similar. The one you don't want to be called is mortality. Mortality refers to, death. Morbidity refers to an adverse consequence. So, for example, if you're morbidly obese, one of the comorbidities would be premature degeneration of your health of your knees. Diabetes mellitus would be a comorbidity of obesity. So when it refers to osteoporosis and vertebral fractures, it results in structural changes of the spine. And if you get excessive kyphosis, you're going to have narrowing or decrease in your thoracic cavity, which might change your pulmonary, function, your stamina, etc., your level of activity and stuff like that. So morbidity refers to adverse effects, and mortality refers to death.
Okay. Okay. Let's see. How about an orthoflex spinal stim to help control pain?
I'm not sure if they're referring to pain specifically due to an acute vertebral fracture, or if they're just referring to generalized back pain. But um, I know that the spinal stems are a means to treat people with intractable back pain that doesn't respond to lesser measures. We don't typically treat osteoporotic compression fractures with the stimulator. But there are some people that have real severe osteoporosis that have had multiple fragility fractures, and due to a combination of the multiple vertebral fractures, whether or not they've even been treated with cement augmentation or not, you combine that with age and arthritis, have back pain issues. So in the context of trying to manage multifactorial, pain, sometimes the stimulators can sometimes be very helpful.
Okay. Are you able to treat any kind of injury up to 10 months or more after the injury?
That is a good question because the cement augmentation is for newer fractures, either what we call subacute or acute. They're not for chronic. So sometimes I get people that come in and they've had an MRI because they've had some issues in their back, and the MRI showed like an older chronic compression, and their doctor sent them in to see if that could be treated. We won't refracture an old healed fracture just to put the bone cement in it, but everyone's a little bit different. If you take someone over the age of 65 or 70 and you treat them just conservatively with an acute fracture, meaning everything except for the surgery itself, about 80% of people will go on to eventually kind of heal, but it could take upwards of 6 months. And unfortunately, you end up with people that kind of end up with these kind of chronic, progressive, non-healed fractures. So the only way we would really know for sure, we would treat someone at 10 months if, they came in and said, I've had this real bad back pain for 9 months, and my doctor did an x-ray and said I might have a fracture, but I haven't really done much about it. My back still hurts. We would do an MRI, and if the MRI, looked like the one I showed you, where there was, acute edema and it was non-healed, we would treat that at 10 months. If it was all healed up, then we obviously wouldn't.
Okay, so that's something you should certainly be seen for, though.
You can always be evaluated for it, and we'll tell you whether or not, what the best treatment might be. It may or may not be a procedure, but
Okay, and there are a couple questions about whether or not you're accepting new patients, so I will answer those now and say yes, definitely.
oh yes, I do accept new patients, and we do have a policy of trying to get people in, in a timely fashion. So
Okay, great. And we will be sharing the contact information in the follow-up email, but you can also find it on the website, trinityhealthmichigan.org. Okay, the next question is about chiroplasty. Can it be done on a lumbar region with vertebrae pressing on the sciatic nerve?
um, it can be done. It's probably not going to help if you've got an issue, and we see this quite a bit. People as they age have quite a bit of arthritis in their back. We call it spondylosis, but it's not uncommon for people to have a buildup of arthritis. They'll have bulging discs, they'll have some bone spurs, they might have a disc protrusion. There may be something that's bumping up against a nerve, giving them some either intermittent or fairly regular sciatic or pain down the leg. Now, if you happen to have that and you were treating it and with therapy and kind of getting by, and then you slipped and fell, and all of a sudden you fractured, you know, let's say you fractured L4, and you had some arthritic changes in L4-5 that were giving some problems. We could treat the L4 vertebral fracture with kyphoplasty. It's probably not going to have an impact on the sciatica though.
And if you've had multiple chiroplasty procedures, so it looks like covering L3 to T12, this person is saying,
Mhm.
they're still having significant pain on the left side and through the mid sideline. Is that something that they should be seen for?
Yeah, I would say it should be evaluated. I'm not, that it there's different reasons for pain. The acute fractures are very painful, kind of right away, and extremely painful with activities. Now, there are a lot of times these fractures are also in conjunction with aging changes or arthritis and stuff. So, I mean, there's a lot of people in the general population that don't have vertebral fractures, but they're dealing with, back pain due to arthritis. So there's a lot of overlap and stuff there too. But there's sometimes where you can have a situation in that region between the thoracolumbar region where because of the compression and treatment, the nerve tunnel of the foramen where a nerve is going out gets a little bit narrow and stuff. So if you're having some pain that kind of goes around, kind of a small distribution, small band around the rib cage on one side, it could be reflective of a thoracic nerve root that's being irritated or pinched. So, I mean, that might be something you might want to have looked at for sure.
How well does the surgery work for people with spinal stenosis?
Kyphoplasty is not done for spinal stenosis, so it doesn't work for that. I've had occasions where someone came in for an acute vertebral compression fracture, and when talking to them, you'll find out, well, yeah, no, my back has really been hurt for 3 days now since I lifted something really heavy. But now I always ask people, well, what were you like before that? What were you doing last month? And then I'll ask them, can you stand very long? Can you walk very far? And it turns out we do the MRI and people have not only an acute compression fracture, but they might have really severe spinal stenosis, which is a narrowing of the spinal canal. I've done procedures sometimes, depending on the age of the patient, health of the patient, and risks, and we discuss it a little bit. But I've had patients where we do the kyphoplasty procedure first, and then we'll transition into a little open procedure where we treat the spinal stenosis. But the spinal stenosis is treated with a laminectomy, which is a surgical procedure. We don't treat the spinal stenosis per se with a kyphoplasty, but sometimes I've treated both simultaneously.
Okay. Okay, so you can be treated with when you have spinal stenosis. That doesn't mean that you're not
Yes.
eligible. Okay.
Yeah, you can be treated. And some people opt. Some people say, you know what, I just want the procedure to fix this new pain I've had for the last 5 days, and I guess I'm okay. I can live with some of the other symptoms I've been having for a couple of years. I want to get the acute pain done. And we'll just do the kyphoplasty and stuff too. Yeah. So spinal stenosis doesn't preclude the kyphoplasty, but kyphoplasty is not done to treat the stenosis.
Okay. And can you only treat one vertebral compression at a time, or can you do more than one when you are doing a
Um,
chiroplasty?
no, you can treat multiple. I've treated up to three. I mean, I've seen people sometimes, I haven't done it, but maybe up to four. I mean, but yeah, you can treat if you got, yeah, if there's two of them, we'll treat them both, yeah. And that's part of the reason for doing the MRI too. I've seen people where, they came in with an X-ray or CT and they've got all the classic symptoms. They get really bad back pain. They get sent over because they've got a vertebral fracture at L1, and it's real obvious on the CT, but the problem is I can't see what's going on. I don't know if they've also got spinal stenosis and stuff. And sometimes people have a fracture of the one right next to it, but it just hasn't collapsed down. So I've seen people that were treated elsewhere. They had a kyphoplasty at T11. They maybe got just slightly better, but didn't really get better. And they come in to see me, and then we get another study and find out, they were treated before. They didn't have an MRI, and they were treated for the one fracture. And it turns out they had another fracture that wasn't treated. So if you got two fractures, you get treated for one, you're probably still going to have a lot of pain. So we'll treat more than one.
Okay, great. And can you talk about the connection between arthritis and osteoporosis? Does one exacerbate the other?
Well, the only thing they from a pathophysiologic standpoint, they're kind of separate issues. The only issue they tend to have in common is that they're more frequent with age. So, as people get a little bit older, you tend to see, I mean, you can see them together and stuff. But the osteoporosis is more about the quality or health of the bone. Arthritis is typically more of a joint problem, so the joints are complicated because usually for example, a knee, you got a couple bones on each side separated by the joint surface, which is cartilage, and then you got ligaments there, and then muscle tendons and stuff. So the arthritis tends to be a little bit more multi connective tissue, which includes cartilage and ligaments. And osteoporosis is really it's kind of a bone issue. So osteoporosis doesn't necessarily lead to arthritis, and arthritis doesn't necessarily lead to osteoporosis. But a lot of people as they're older kind of have both issues. But
Can you be too young or too old to get a bone density test?
well, it's possible you could be too old, I guess. I don't know if you're 95 years of age and living in a facility, probably not all that, maybe not all that practical. But if you have it depends on risk factors and stuff. I mean, I don't think if they're healthy 30-year-old people with no risk factors need to be having bone density tests. But if you've been someone who had childhood asthma and you've been on bronchodilators and corticosteroids, all your life and stuff, and you're getting in your 30s, that might be something you want to discuss with your primary care physician, or or something like that. Or if you had a fragility fracture, let's say you're 36 years old and you were lifting a pallet of water and you end up having a vertebral fracture, which would be extremely unusual, then it might be worth, doing a DEXA scan and pursuing it. But I don't think just for the average healthy young person without risk factors that you need to be moving the bone scan age up a lot.
This person is asking, it sounds like they have some pain. Hang on, I'm looking for the question again. They're having some pain in the thigh, groin, knee. Could that be coming from their back?
I mean, it could be. It wouldn't necessarily be related to osteoporosis, but people sometimes can have issues in their lower back, um, whether or not it's a disc issue or arthritic bone spur issue, where the pain from the back is frequently kind of referred into the leg. So yeah, that's always a big trick because you have to kind of differentiate whether or not, is this an arthritic hip that's kind of hurting in the groin, or, do you have a kind of arthritic hip and a bad knee and stuff. So yeah, it becomes a little tricky there too. But problems in the lower back certainly can be referred into the leg. So it's something we typically have to sort out.
Okay. How effective is hormone replacement therapy for preventing advancement of severe osteopenia to osteoporosis? And this is someone in their early 70s.
It's helpful. There's like a couple different types of hormonal treatment. The being on the estrogen replacement is definitely is helpful, and also calcitonin is actually another kind of hormonal. It's a natural ubiquitous, and then there's the bone builder that we talked about, which is the parathyroid hormone supplement. So those are all kind of mainstays that can be definitely be beneficial. They're all can be helpful for sure.
I will say traditionally, I have always thought that dairy products were like the best source of calcium, but what you've said today is if you're eating the rainbow, right, the veggies and fruits, that you really can get the calcium you need without eating a lot of dairy products. Is that an accurate statement?
Yeah, I think so. All our dairy products pretty much are, supplemented. The problem you have is I used to love dairy products until I became lactose intolerant. So if you're someone out there like me who's kind of lactose intolerant and now you can't really have the dairy products, you got to look for other sources. So, like you say, if you like fish, like some of the fish that have small bones in it, you get both vitamin D and calcium in it. Sardines are type. Then those green vegetables I mentioned actually tend to have pretty decent calcium in there. So there are some food sources, that you can use.
There are a lot of questions about vibration therapy for bone health.
Mhm.
That something that you're familiar with, and do you recommend it?
Um, it's you know what, it's a little bit newer. I haven't ever used it personally, but actually I've seen a little bit of it. And actually I think there could be a role for it. I'm not familiar with the science behind it. I can't tell you the science on it, but I have seen references to it and I've seen it described. And actually I kind of think that the vibration treatments could actually be effective because you're kind of basically getting a little bit about kind of like a pulsed um, resistance. It's via vibration as opposed to something you're doing physically. But I think there's the chance that could be helpful. And we know that bone cells will respond to external things. That you'll see a lot of professional athletes that you have a fracture in their hand or their arm, and when they're treated, they use an external um, electronic device that creates an electronic magnetic field around there that really helps with the bone cell healing and stuff. So we know that the bones and bone cell activity are responsive to external factors, and vibration might be one of them. I don't know.
Okay, how about foam rollers? Do your patients get relief from using a foam roller?
Um, Again, for osteoporosis, it's probably not most probably that all that helpful, but foam rollers are great. I've actually I got personal experience with foam rollers too. For they work really good for things. I've used it because I had kind of an IT band hip issue, so you can use it for that, but you can use it in your back. But yeah, foam rollers are great. They're it's part of that stretching flexibility. And if you want to use a tennis ball back there or a foam roller, or you've got a chiropractor, a therapist, or someone stretching and stuff. I think the foam rollers are great.
And then there are several questions asking for other symptoms of either osteoporosis or a vertebral fracture.
Mm.
So, could one of them be hand pain and like a freezing kind of your hand? Um, and then some other questions about onset of sciatica, nerve pain. Can that be a sign of a fracture? Or,
Yeah. So, not as I mentioned, not all osteoporotic fractures are symptomatic. So we've got the asymptomatic ones. We usually refer to pain. So not all these fractures are painful, but other symptoms you could have would be a loss of height. There are a number of people that have had multiple fractures, and ask them, like, my back's never really hurt. I never have a fracture. So you can have kind of the silent loss of vertebral height or multiple compressions over time that aren't particularly painful. So you would notice either a loss of your height, your driver's license used to say you were 5'7", all of a sudden you realize you get measured, now you're 5'4". Or you might visibly see yourself in a picture, look in the mirror, or someone might comment and say, "Gosh, you're kind of hunched over a little bit." You've probably all got an aunt or a grandma or someone you kind of know what I'm talking about. But those are probably the most, aside from having an unexpected fracture of the wrist. Those are probably the most common things you're going to know. Other than if you get screened and stuff, those are probably the only symptoms you have. Sciatica is not it's pretty unusual for someone to have symptomatic fracture of vertebral body that causes sciatica. Sciatica is very common. It's usually a lot more reflective of arthritic changes in the spine, etc. It's very rare that someone who's never had sciatica all of a sudden has a vertebral fracture and now they got sciatica. We just don't see it that often. So typically, sciatica is usually more likely associated with osteoarthritis and probably not really directly as related to osteoporosis, although with an aging population, there's a lot of overlap. So we see both problems in a lot of people. So usually, if you only got one, you've got the other, you got both. So
and there's not typically any type of bruising on the back or anything that you could see kind of exterior.
unless someone had a fall, I mean, we have people, tripped in the bathroom, fell on the bathtub, they might fracture a couple of ribs and have a bruise on their flank, and they also have a vertebral fracture. But other than if you got directly, hit on the side externally, generally there's not any external bruising or anything like that.
Okay, and osteoporosis is not something that impacts women only, correct? Men can also experience that.
That's correct. That's correct. It's a lot more frequent in women. It can affect men. I will say that when it comes to treating osteoporotic fractures, especially the non-traumatic ones, like men and women seem to fall equally. So when it comes into a certain, you're looking at people in their 70s, 80s, and plus, they come into the emergency room and they've had a mechanical fall. We're seeing both men and women, probably more women because there's more women around, but that's kind of an equal opportunity thing. But when it comes to just kind of like a spontaneous fracture in a 75-year-old, I mean, for every 10 I treat, there's probably 9 of them are women. I mean, so it does happen in men. It's, if you have a secondary factor, if you're a man who's got COPD and you've been on steroids, or maybe you've been treated for, rheumatoid arthritis with steroids, you're just as equally susceptible and stuff there too, but definitely more common in women.